But first, I want to introduce you to him. At the time of HCC diagnosis, my superhero Warren was 63 and a true Renaissance man. An avid tennis player, he loved Hawaiian shirts and Publix grocery stores, as you can see. He developed black and white photography and was on a competitive barbecue team known as Apocalypse now. He loved being a grandfather to our 2 young grandchildren. He was passionate about his career as an electro-optics engineer in the defense industry and was the optics guru for a gunfire detection system used by our troops and used by many large cities today commercially. Our world crashed in March 2019 when he was diagnosed with stage 4 HCC with a 3 to 6 month prognosis. He lived 27 months until June of 2021. We didn't know it, but we had started on the HCC road the year before in 2018. Warren was a smoker, overweight, and insulin-dependent diabetic. Fatty liver had been casually mentioned, but never as a concern. The need for back surgery in January 2018 started a domino effect. A pre-op EKG was abnormal, and we learned he needed open heart surgery. The pre-operative open heart surgery showed elevated liver enzymes and prompted a GI workup and consult. Warren had a normal tumor marker, AFP, and EGD, but the ultrasound showed cirrhosis with hepatic sclerotic masses. A CT scan showed nodules of no concern per the GI, and an ultrasound liver biopsy showed cirrhosis and regenerative nodules with fatty liver. The diagnosis, we were told, was mild cirrhosis, and he was cleared for open heart surgery in February 2018. Warren was a beer drinker, and he immediately stopped all alcohol. Liver enzymes went back to normal. Our GI-MD was an Ivy League educated medical director at the hospital, so we thought we were in good hands. At each follow-up appointment with him, we asked what surveillance was needed for cirrhosis. His response was liver function test and occasional ultrasound because Warren had stage 0 cirrhosis and no other risk factors. Follow-up ultrasound that April showed stability of the nodules, and liver function labs in April, August, and November were normal, except for a slightly elevated alkaline phosphatase, and the GI said that's of no concern. An AFP was never done. The GI sent us back to our primary care doctors and said his cirrhosis was so minimal you wouldn't even know he had it, and we didn't need a GI doctor. After 2 surgeries and a liver scare, we were so happy he considered cirrhosis a non-issue, we accepted what he said. As a case management nurse, I thought I was adept at navigating the medical world. But you have to know what you need to navigate. What we didn't know, Warren had almost every risk factor for HCC. Fatty liver, alcohol use, mild cirrhosis, diabetes, obesity. But no one told us these were serious risk factors for liver disease or HCC. We knew alcohol was associated with cirrhosis. He stopped drinking alcohol. His liver enzymes were normal. Ultrasound was stable. The GI doctor minimized the cirrhosis and said we didn't even need him, and that he had no risk factors. So we thought everything was good. Though we had always been diligent with getting copies of medical records in the whirlwind of 2 surgeries and a liver scare, we did not see that CT report, which said at least 2 areas of delayed enhancement demonstrated within the liver. Appearance non-specific, but multifocal HCC would be a consideration. Evaluation of the liver with EAVIST MRI is recommended. I will never know if that would have made a difference. But I do know if we had seen that CT report, we would have asked different questions, we would have researched HCC, and we would have gotten a second opinion. Fast forward to March 9, 2019, the next year. Our primary care doctor sent Warren for an ultrasound for right upper quadrant pain of 3 to 4 weeks duration. Unbelievably, the ultrasound showed no change in the nodules, but now there was portal vein thrombus. Our PCP was alarmed and he contacted the GI doctor who said, oh, this is common in cirrhosis, but I'll do lab and I will do an MRI. The liver function tests were still normal, but now the AFP was elevated at 64. and the MRI showed 8.8 centimeter tumor in the right lobe in the setting of cirrhosis, consistent with HCC. Tumor in the veins, several satellite metastatic nodules. We were stunned. How did we get here? No risk factors, stable ultrasound lab, stage 0 cirrhosis to stage 4 HCC in 1 year. Warren's team members are in bold on this slide, and it was providential we overheard the name of an interventional radiologist who had success treating HCC, and we requested him. He was personally invested in liver diseases because of a past issue. He said he would do a biopsy, but from the MRI, he was sure that Warren had advanced HCC with a likely 3 to 6 month prognosis. He immediately recommended Y90 treatment, and his nurse navigator quickly obtained insurance authorization, and we were scheduled the next week. He contacted the oncologist we had not even met yet and discussed systemic treatment with Lenvima. I wanted to explore NCI centers, but Warren wanted local care, and COVID was an obstacle. But I have to say, these two doctors were an outstanding cohesive team, even though they were at different facilities. It's very unusual to have an IRMD as a treating MD along with the oncologist. The oncologist would see us first. Labs and scans were done every 2 to 3 months, and the IR would review the scans with us, which was important. My husband is an imaging expert. It's crucial to balance HCC treatment with quality of life and not impacting liver function. These two phenomenal MDs thought outside the box and were proactive with not upsetting the apple cart, and Warren's liver function remained good throughout treatment. We felt part of a team with them, and we never heard from that GI Ivy League educated doctor again. I love this slide. Warren gave this radiation site assigned to his IR doctor when he had Y90, which still hangs on his office door. My husband had a dry, sharp wit that endeared him to his doctors, and when told after having Y90 he couldn't sleep with his spouse for a few days, he said, "Well then, whose spouse can I sleep with?" His treatment included 2 Y90 procedures, 1 DEB TACE, remarkably only 1 paracentesis, and immunotherapy targeted med combinations, all of which kept his HCC under control for 27 months. He was never hospitalized for HCC, never was in the ER. He had a weight loss of 60 pounds, and side effects were managed with meds. He had pain pills on hand, but never required them on a daily basis. His MDs were hopeful, compassionate, and honest. The treatment was palliative, not curative. Every med change was a bridge to another treatment. And you can see we had a lot of bridges. But we were encouraged by the rapid evolution of meds for HCC, which is the direct result of you that are providers and organizations like AASLD. We learned to live the in-between of the next scans. Warren reduced to working part-time, but continued working 1.5 years. In April 2021, her younger daughter got engaged and planned a wedding for the following January. What we now know as God's prompting, she suddenly decided to have a backyard wedding in May, 4 weeks to the day before he would suddenly pass away. These slides show his last month of life. A family beach trip, our daughter's wedding, our granddaughter's first birthday, a company car contest, Yoo-hoo happy hour with our grandson, and if you guys don't know what Yoo-hoo's already missing out. And a Father's Day baseball game, which was only 6 days before we lost him. He was truly living with cancer. Bias, assumptions, and delays lead to bad outcomes. June 26, 2021 is still hard for me to talk about because of that. Warren woke up early with a different intermittent abdominal pain, some diarrhea, and an unsteady gait. And when I couldn't get a blood pressure, I called 911, and he was transported to the ER, which is a regional level 1 trauma hospital. He had just started lactulose for some mild cognitive impairment, so I thought he might be dehydrated. Of course, it was a Saturday when his regular medical team wasn't there, but I took in copies of everything, his scans, his labs, and I asked for consults with IR and oncology. Imaging was unchanged, and mild anemia was noted at first. Treatment included pressors for low blood pressure, IV antibiotics in case of sepsis, and transfer to ICU when bed was available. A surgical consult was requested, but didn't occur until mid-afternoon, and the surgeon was dismissive, saying the symptoms were due to ascites despite no supporting imaging evidence, and telling me no surgery was needed, and if it was, it would be a very different conversation, which led me to know he was biased by that stage 4 cancer diagnosis. I asked for a different surgeon, which was denied, and then I asked for a GI consult. No one ever asked his activity level, how much pain medicine was taken, if he ever had a blood transfusion. On-call IR was finally contacted and requested a CTA, but before it could be done, Warren's condition rapidly declined. A drastic drop in hemoglobin and hematocrit was discovered too late. Blood transfusion was delayed by the late arrival of blood, though I overheard discussion about emergency trauma blood that was on hand. Despite being there all day, intervention came too late. Warren passed away from hemorrhagic shock. We knew he had a terminal diagnosis, but we were devastated by the suddenness of this loss. At the last appointment with his oncologist, he said, we're going to eventually run out of options, but we're not there yet. Bias, assumption, and delays can lead to bad outcomes. Our PCP used to joke, I was a what if, and Warren was a so what. These are our what ifs and so whats in this situation. What if we'd been told about MASLD, HCC, and MASH when fatty liver and myelocirrhosis was first mentioned? Our so what was led to ignorance of liver disease and metabolic ties. What if we questioned the minimization of cirrhosis, the type of surveillance being done, and requested a second opinion? Our so what? Warren had stopped drinking, his LFTs were normal, the GI said he wasn't needed. What if we had seen that CT report and requested the MRI? The so what? We trusted the GI, and he said the CT was fine. What if we had ER doctors who weren't biased, didn't make assumptions about stage 4 cancer, and interventions weren't delayed? So what? There's not a so what. This is an even if, which is why I'm here sharing our story. You all have a unique opportunity earlier in the liver disease process to help yourselves or help your patients if you're a provider, and hopefully prevent our what ifs. These are some ways to empower patients, and Dr. Spann and Dr. Brown have already gone into great ways. So I'm just going to highlight a few. Education is critical. Information pamphlets, educational support resources, communication and coordination, sharing test results quickly. Portals do help, as they alluded to. Patients can misinterpret results and it leads to anxiety. Encourage patients to get copies of their records and not be afraid to ask for a second opinion. Care navigation and access. You can reduce delays with same-day appointments and testing, and patients can also call and request for cancellations to move appointments up and get earlier appointments. Connect patients and families with point people other than medical doctors, such as a nurse navigator or social worker, which has already also been alluded to. You guys are fantastic. We had both of those. External nurse navigators, also known as case managers, and chronic disease management programs are a great resource. They are a bridge between appointments that can escalate issues to you guys early before things start happening. So these are people that are outside the hospital system. The hospital called to cancel the paracentesis, the only one that Warren ever had the day before, because they didn't have insurance approval. I contacted our insurance company and was told by somebody clearly non-medical who was reciting guidelines that he did not meet criteria. I asked to speak to a case management nurse. I was able to obtain authorization. Use those resources. In the real world, I know that providers have heavy patient loads and can't spend the time they want to spend with education, and you've been given some great resources here today, but these are a few more. And I have to highlight Andrea's Blue Faery Foundation, which supports HCC patients and liver patients, because it was a godsend to us when I found it. Other people living with HCC and all this medical information that we had not been given, and it gave us so much hope. Point your patients to trustworthy resources, or if you're a patient, use the ones that they've shown you so that you're not relying on the popular Dr. Google. Throughout Warren's treatment, we sent cards and family pictures to his IR and medical oncologist to thank them for the milestone moments we were able to have, thanks to them and God's provision. I gave them these mugs with Warren's favorite quote from when our girls were growing up. No life is ever wasted, you can always serve as God intended. Warren's life was certainly neither, but there are lessons to be learned from our experience. Our wonderful IR was seeking an answer, and he reviewed the scans on his own and saw a small clot and a fragile compensatory vessel in the liver that had likely ruptured. As hard as it has been, our family has chosen to look at this as God's gift to our superhero, because it spared him pain, deterioration, and even hospice. He was fully living until that last day. But I ask you to please make his journey count. Avoid our what-ifs. Education is critical. I'm a nurse, and I did not know the information that was shared with you here today. AI wasn't available. Comprehensive surveillance saves lives, especially with the chronic liver conditions many of you are living with or are treating. Encourage patients, or you guys, if you're patients, keep copies of your test results. Don't just assume that you've been told the correct thing, and ask questions about those results. Educate your colleagues or your doctors if you're a patient with the rapid evolution of treatment options. It's critical to educate the medical community, especially in the ER. Stage 4 is not an imminent death sentence. It can be a chronic, treatable, manageable stage of living with cancer with treatable complications. This light in the sky appeared a few days after losing Warren and has special significance to our family. Warren really thought he would be HCC, and he never gave up. Hope was a constant. Our family expresses our thanks to Andrea for her dedication in founding of Blue Faery, which is a lifeline of hope, education, advocacy, and support delivered in HCC patients. We thank you, all of you, and AASLD for their untiring efforts with research and treatment for liver disease and the desire to learn by your presence here today. It's through collaboration and opportunities to share experiences like ours that other people can avoid Warren's journey, and we can continue to provide hope to patients and families. Thank you for allowing me to share my superheroes.